All right, good morning, everybody. Thanks so much for making it out in the rain and first thing on the last day of the conference. Really appreciate it. Also appreciate very much Adam and the other organizers for the invitation to speak here today. So Adam and Mike really set this up nicely in terms of transitioning from yesterday, building on what we've heard about and trying to talk about how modeling can maybe identify some ways forward or at least propose some ideas or stimulate some thinking about how we put all this together to actually try to achieve the dengue endgame that we're all seeking. So Laura presented this data on the first day of the conference. This is reported cases of dengue to PAHO annually over the last few decades. We see that this is just growing really out of control. It's difficult to imagine what next year might bring, but it's clearly a huge problem and growing even bigger than we initially thought. So we know that there's a problem. We know that there are some tools available, but so far at this conference, we really haven't tried to think about how we tie all these things together to try to achieve the end game, which is really what I'm going to try to move us towards with this talk today. So let me also address why modeling has anything to contribute to this discourse. There are a few reasons why I think modeling is actually essential to serious thought about strategizing towards an end game. The first is that clearly there are no silver bullets for dengue. If we had a highly efficacious, durable, safe vaccine that worked against all 4 serotypes, we wouldn't really have to be having this conversation. We would just be having a conversation about how to get as many people vaccinated as possible. Unfortunately, that's not reality, and so that and other limitations of other interventions and other challenges of this situation confront us to think more carefully about a complicated problem. Another issue is that whether it's vaccines or any other intervention, trials are extremely hard to do for one intervention alone, especially for something with very heterogeneous epidemiology like dengue. And so when we're starting to think about combinations of interventions and staggering interventions and all the complicated ways that we could approach this problem, it really becomes intractable to try to evaluate each of those different strategies empirically in the form of a trial or even in an observational study. And so modeling can really allow us to explore a very wide range of problems or strategies before we invest or commit to putting those ideas into practice. And then finally, something that isn't often appreciated is that extrapolating from trials into a public health context is not always straightforward. So we hear an efficacy number, and you may imagine, oh, we can just plug that in, and we'll imagine that cases will be reduced by that much. But it's actually not so simple for a variety of reasons having to do with the complexities of transmission and this disease's epidemiology. So all of these factors really make it such, in my opinion at least, that we really have to use models if we want to think seriously about what to do about this problem. So just to really explicitly and clearly frame the question I'm trying to answer, I'll put it this way. So based on current scientific and understanding and public health tools, which we've heard a lot about over the last couple of days, what would it take to actually achieve the dengue endgame that is the theme of this conference? And the endgame is not necessarily elimination or eradication, but even just control of dengue in a sustainable and long-term fashion. So I actually had the good fortune to speak here last year. Some of you may remember seeing me there. I talked a little bit about the model that I'm going to present to you today, so I'll just briefly recap some of that, but I do have quite a few new results to share, which is where I'll try to spend the majority of my remaining time. But I do want to motivate some thoughts about what we need in a model in order to address this question. So when it comes to modeling, we can all have different sort of pet ideas about factors that are important and that should maybe be included in a model, but we also want to be judicious about thinking about what's really needed in a model to address a specific question. Some questions may necessitate a very complicated model. Other questions, maybe we can get away with a much simpler model. So what are the features in a model that we need to address this question of how to approach the end game? So one factor that I would propose that we need to account for are long-term dynamics. Often modeling is done, we model a single epidemic, or maybe we model 5 years into the future. But this is really a long-term problem that we're thinking about, and so we have to have a model that's equipped to account for factors such as immunity and susceptibility dynamics, demography, as Derek pointed out a couple of days ago. So long-term dynamics are really important here. Also capturing the effects of different interventions. The different interventions, vaccines and the multitude of forms of vector control that Rebecca highlighted yesterday, they work in a variety of different ways, so we want to be able to capture those nuances. Also, cost effectiveness is important. We could easily say that if everybody had a vaccine and everybody sprayed their house on a daily basis, there would be no more mosquitoes, but things like that aren't possible. So we want to keep in mind cost effectiveness in proposing realistic solutions. And then finally, I would argue that it's important to account for the diverse epidemiology of dengue in different local contexts. There very well may not be a one-size-fits-all solution to this problem. Okay, so I'm just briefly going to walk you through some of the features that our model has, just to give you a bit of a visual and intuitive sense of what's going on underneath the hood. So the first feature of the model that I'll draw your attention to is that it has a somewhat simplified, but I would argue sufficiently realistic description of the epidemiology of dengue within an individual. So if we start at the top left, a person is susceptible to all 4 serotypes. They get their first serotype infection, and that works like an SIR process. They get infected, and then they recover and become immune. They then move down to the second row when they encounter their second serotype, and so on and so forth until they've encountered all 4 serotypes. Meanwhile, we have children being born who, after maybe a short initial period, are going to be fully susceptible, and we have people in all of these different stages who are dying over the long-term time scales that we're thinking about. And they die at different rates, right? Because people who have had all 4 serotype infections, they maybe have a higher chance of death. Those who are naive, they're probably younger and have a lower chance of death. So we account for factors like that. I will say importantly that we don't track individual serotypes, which is an important limitation of the model, but I think it's one that's difficult to improve on much given the limited data and understanding that we have of serotype circulation patterns globally. Moving down to the bottom left, I just want to highlight some of the demographic features that we have. Again, this is building on some of the important issues that Derek brought up a couple of days ago. So there are really 3 key demographic factors that we have. One is births, one is deaths, and then the other is urban growth. So our model actually focuses on dengue within cities. So we apply the model to the unit of a city. There are a couple of reasons for that. One is that dengue tends to really be focused in cities, not strictly limited to cities, but focused there anyway. And also it's mayors and officials at that level that are making decisions about how to control and respond to dengue. So we focus on cities and therefore account for urban growth, because if you just look at birth and death patterns, that ignores the important factor of immigration into cities, which is actually a big phenomenon and quite significantly shapes population sizes within cities, as well as the potential dynamics of susceptibility. So this model that I've started to illustrate to you, we apply it to basically each of the dots on this map. Each of the dots on this map is a city within a country where there's evidence of dengue transmission, and each of these cities is, I believe, above 100,000 individuals. So that's any city that falls into that category. We're taking a look at with this model and trying to tailor it to the local phenomena there as much as possible. One important input to tailoring it to these different cities globally is that we rely on a very nice product that was developed at Imperial a few years ago, and that I believe Ilaria will be telling us a bit about an update on in the next talk, where they've mapped the force of infection of dengue virus globally. And so we take this model, or this map, as sort of a key sort of input for calibrating our models. So we want to make sure that on average our model is reproducing the same force of infection that they've estimated. So they've really done the hard work of rounding up the data to do this and modeling it statistically, and so we're sort of building on that by using it to sort of anchor this mechanistic dynamic model. And then just to give you a sense of sort of what our model can do to build on this static map is that it allows us to have instead a dynamic picture of what's going on with dengue. So here you see over the course of a 10-year period in one of these cities, we see a time-varying sort of seasonal pattern of transmission that again reproduces that average force of infection, but does so in a way that captures those seasonal nuances. Okay, so that's the model. I want to spend the rest of our time talking about specific questions about strategies for controlling dengue and the different tools that we have at our disposal. So the place that I want to start here is to think about existing vector control tools that we have, and to at least, we at least want to first rule out whether they can get the job done alone if done as optimally as possible. So that's really the starting point here. And again, Rebecca did a really nice job covering the immense variety of vector control tools that are out there, so it's hard to really cover all of that diversity of approaches. So instead, we focused on one approach as sort of a representative example of existing vector control tools. This is indoor ULV spraying, and we've modeled this after the city of Iquitos, Peru, where I've had the good fortune to work with collaborators there for a number of years who have really studied these issues in detail and really quantified how things are done there and shown evidence that they have both an entomological and an epidemiological impact. So just to walk you through this, in Iquitos, the way that the city does this, and this is not in the context of a research program, but in the context of an actual public health prevention program, they basically go through the entire city of Iquitos, which is around 400,000 individuals, and they basically knock on every door 3 times and attempt to do indoor ULV spraying. They have the capacity to cover around 11,000 homes per day. So basically doing these 3 rounds of spraying within the city, they can do this within a few weeks. So they basically do this once a year. And there's obviously an important question of the timing of when you do this. Do you do this before transmission starts? Do you do it after cases have ramped up? The seasonality of dengue in Iquitos and many other places varies, so it's a bit of a tricky question about when do you use this really sort of resource-intensive effort that they go about doing. So in any case, on average over time, it's been found that this campaign that they do leads to a roughly 60% initial reduction in mosquito densities, and that then the mosquito population rebounds on a time scale of 2 to 3 months roughly. So this is just sort of one sort of scenario for how existing tools might work that we're looking at with this model. So our question then is, like I mentioned, what's the timing of this? How long do you do it? Do you do 3 rounds, or maybe 2 rounds of spraying is enough, or maybe you need to do 4? These are the types of questions that we can start to explore with the model. And specifically, we're using some tools that I think have been somewhat underutilized actually in infectious disease modeling, which is a mathematical toolbox called optimal control. And what optimal control does is it actually tells you what is the optimal time-varying pattern of application of a control measure, such as spraying, that would balance some, sort of ratio of cost to benefits. So that's essentially what optimal control is doing. It's giving us this sort of free answer, so to speak, about how we go about engaging in this complicated rollout of an intervention. At the top left, I'm just highlighting that we actually explicitly model the coverage of the intervention. So there's an input to that coverage that's actually going out and applying the intervention. But then, of course, it decays over time, some time scale in terms of the effectiveness of the intervention. And so we essentially sort of take a weighted average in the city of areas that are under control and that are being impacted in this way, and those that are not covered. So we're accounting for the fact that this is not a perfect intervention, that it has limited coverage, but it still has the benefits that I described on the previous slide. And the answer that we get out looks something like what's on the bottom right. So anywhere you see that gray bar, that's saying that's a time when you should be out spraying. When it's white, it's okay to not be spraying, and that's the balance that it strikes in terms of optimizing the delivery of this intervention. So I'll have a few slides that look something like this. So on the left, we're going to look at disease burden. On the right, we're going to look at costs, because again, we're trying to balance those two and account for both of those considerations. So we're looking at things on an annual basis. The gray that you see in the background, that's the baseline where we're not applying any interventions above and beyond, just sort of a status quo sort of scenario. And then this black line is showing after an initial period of 5 years where we're just adhering to the status quo, what if we go out and we apply this ULV indoor spraying like they do in Iquitos? What if we do that according to this optimal control solution? What if we do this as best as we possibly can? So in this scenario, we see that we could achieve potentially a big initial reduction in hospitalizations, and that could have some benefit over time as we continue with our spraying program. But despite the fact that we're actually increasing the spraying, which you see reflected on the right, you see those increasing costs as we go into 2040 and beyond. So we're actually ramping up the costs associated with our program because we're spraying more and more. Despite that, the hospitalizations are returning to their initial starting point, essentially. The reason for this unfortunately, is something known in infectious disease dynamics as a honeymoon effect. That is, you can have some initial success with a control program just by reducing the reproduction number, but over time you have an accrual of susceptibles as you get more effective with your approach, and it actually makes it harder and harder to maintain that. So this is actually a really important phenomenon that comes out of this model. All right, so moving on from there, it doesn't look like existing vector controls are up to the challenge of achieving the end game, even if done really, really well. So let's think about a vaccine and how that could help us out. So I'll just briefly say that we've done a separate analysis of published data on the Takeda vaccine to estimate some inputs for our model in terms of its efficacy profile. These are largely consistent with what you saw presented yesterday. There's obviously serotype and serostatus dependent differences in the efficacy, but we have our own estimates of this that are, have some differences and that also capture uncertainty in a way that we feel comfortable with. I'll also say that we account for protection against disease and also protection against hospitalization, whatever that means relative to our conversation yesterday. But something that we don't account for, that we are assuming somewhat pessimistically, is that there is not prevention of transmission or blocking of infection. I think until data is presented that actually make a case that that is happening to a large degree, we feel a little more comfortable with being conservative and assuming that we're mostly treating the symptoms, so to speak, rather than preventing transmission or having substantial indirect protection. So just to show you what this looks like, if we do only vaccination, we're not doing any additional vector control above and beyond. On the left, we explore a range of different coverages of the vaccine program. We see that in all of those cases, after we start rolling out the vaccine, by let's say 2025 to 2030, we do see over time a decline in the number of hospitalizations that we would expect. That makes sense. The vaccine does have a protective effect against hospitalizations. Of course, that's serotype dependent, but we're looking at this in a somewhat serotype averaged way. So on average, we would expect there to be a benefit like this over time. But interestingly, when you look at the costs, of course, there's some initial increase in costs associated with the vaccination program itself, but there's actually not a substantial cost savings in the long run. And that occurs for two reasons. One is that we're assuming that there are no indirect effects that are coming from the vaccination, so it's not that it's getting rid of dengue, in terms of a sort of herd immunity type scenario. And then the other factor that's somewhat interesting is that we use costs for different types of dengue cases, so non-medical, ambulatory, hospitalized, and death, according to numbers that Don Shepard has estimated. And we actually found that if you move people from the hospitalized category to the ambulatory category, there's actually still a considerable expense associated with that. So it may not result in a really substantial cost savings. So, I think this looks positive for vaccines in the sense that it certainly can help improve people's outcomes from a health standpoint. But again, it doesn't appear that it's going to be a solution in its own right. Now, if we combine this with vector control, so if we basically take the two approaches I've shown so far and merge them together, we see that we kind of get what we'd expect. So we do have a benefit of vector control in terms of knocking transmission down for a while, but you do get this rebound, and maybe the vaccine helps somewhat. But again, together they don't really solve the problem in a long-term way. Next, I'll move to Wolbachia, which is another major class of intervention that there's a lot of excitement about. We're basically taking a mosquito population. This is the WMEL, or replacement version of Wolbachia, and we're replacing the mosquito population with mosquitoes that have this intracellular bacterium that confers a form of resistance to infection and that slows transmission to a degree that actually could be quite exciting. So on the left are results from a New England Journal of Medicine paper that was published a couple of years ago, reporting on the results of a trial from Yogyakarta, Indonesia, where they found a 77% efficacy against their endpoint, and this covers all dengue virus serotypes, so that's very significant. I just want to briefly mention that we published a paper in BMJ Global Health about a year ago that actually argues that this 77% efficacy, even though that's really great, it's probably a considerable underestimate of the true efficacy. So this is a really exciting and promising intervention, and maybe that's enough. Let's take a look and see what the model says. So when we apply WML in the model, we're rolling it out, and during that initial few years, much like the existing vector control tools, we expect there to be a drop in transmission. You're reducing transmission, and so you're going to have a pretty drastic sort of nonlinear effect on hospitalizations and also the costs that come with that. But over time, we see a rebound as well. We varied the coverage of Wolbachia. We see that in places like Yogyakarta, this bacterium can get to very high levels, whereas in other places like Rio, it struggles to achieve those high levels. So even across that range of variation, we're still seeing a rebound after some period of time. Although I will note, importantly, this is just one representative scenario. If we look at places with lower transmission intensity or maybe a different local epidemiology, potentially there could be more sustainable long-term impacts of Wolbachia, but at least in this case, in a moderately high transmission setting, it looks like it's going to have a limited duration of protection for the population. Although once we start to combine WML with those existing interventions, that's where things start to get a little more interesting, because with that sort of 1-2 punch of those two different approaches, and with the sort of persistent application of those existing vector control tools, that's where we start to see the possibility of those longer term reductions in transmission, just because we're lowering the reproduction number of the virus to such an extent that immunity or the buildup of susceptibility has a harder time countering that and getting transmission going again. Okay, I'm over time, so I'll just briefly mention this, but there's some really, I think, very exciting and compelling ideas that are being developed by a Lancet Commission on dengue and other Aedes transmitted viral diseases. So Eng Yang is one of the members of the executive committee of that Lancet Commission, so I would encourage you to talk to him if you're interested in that. But just to kind of briefly summarize some of the ideas and arguments there, is that the thought is that the only way that we're really going to achieve sustainable long-term dengue control, that is the dengue endgame, is by not just sort of throwing one intervention or another at this problem, but by really trying to address the underlying cause of the problem, which is the mosquito in the urban environment. What this actually looks like, the sort of shorthand for this is building out Aedes, but what this actually looks like will inevitably vary considerably across different populations. In some cases, it could involve housing improvements. In other cases, it could involve investments in infrastructure. Scott Halstead mentioned that dengue is a problem of piped water access, and so maybe that's one important solution in a lot of places. In any case, the argument here is that, in addition to the interventions that I've covered so far, let's think about these longer-term, more sustainable approaches to dengue control. So that's the idea of the Lancet Commission, which you'll be hearing more about in 2025, I believe, as they release their report. But I just want to briefly show some results where we've looked at this idea with a model. And so what we've done here is basically just steadily reduce the force of infection of dengue over time, and we're doing so at a rate that's consistent with what was observed in Singapore during its development. So we do see and expect here a steady decline in both hospitalizations and costs associated with the burden of disease, but it does take a while to get there, even under this relatively optimistic yet realistic assumption about a Singapore-like scenario. However, once we start to combine that approach with some of the other interventions that we have available, that's where things start to get even more promising. So here, if we just do the building out and then use the existing vector control tools that we have really effectively, as optimally as possible, that's where we can really both knock down transmission and keep it low potentially by this combination of these both short-term and long-term approaches, which of course have very long-term cost savings in terms of existing vector control programs. And then, of course, if we throw WML Wolbachia in the mix, we can have sort of similar approaches. So maybe in some cases it might be using Wolbachia and building out. In other cases, it might be using existing vector control tools, whatever that is, whatever is locally appropriate and works in a given setting. But whatever the case, I think this is pretty clearly pointing towards using a combination of both short-term enhancements of control and long-term investments in addressing the underlying problem as really the most robust solution that we're finding for addressing dengue and achieving the dengue endgame. So with that, I'll just leave these conclusions here and not say much more about it, given that I'm over time, and thank you very much for your attention.